Welcome. I'm Sebastian Mahfood, and you're listening to WCAT Radio, the on-air wing of En Route Books and Media, bringing you the dulcet sounds of Catholic wisdom.
Good afternoon, and welcome to WCAT Radio and this edition of Inter Vitam et Mortem, Between Life and Death, Interviews and Discussion with a Catholic Bioethicist. I am your host, Dr. Anne Urlakis. I am a classically trained and degreed bioethicist, and today I have a special guest, Dr. Paul Hruz, whom I wish to introduce to our listeners. But before we begin, let us start, as we always do, with a prayer. In the name of the Father, and the Son, and the Holy Spirit. Dear God, our heavenly Creator, you are the author of life and of truth, the reality that you will each and every human person into being, created from the moment of conception, bearing the dignity and imprint of your own image and likeness within the very essence of our being, is a mystery beyond human understanding. Please help us to have a greater appreciation of the gift of being created in your image and likeness. Help us to reverence that reality in our brothers and sisters, especially in the tiniest and most vulnerable among them. Help us to defend the sanctity of every human life from conception to natural death. Through the intercession of Our Lady, the ever-pure and all-immaculate, Blessed Virgin Mary, in the name of the Father, and the Son, and the Holy Spirit. Amen. Again, thank you for tuning in to this episode of WCAT Radio's Inter Vitam et Mortem, Between Life and Death, discussion and interviews with Catholic Bioethicist. Today I have the privilege of speaking with Dr. Paul Hruz regarding a very important yet sensitive subject of gender dysphoria. Dr. Hruz is a MD Ph.D. He is an associate professor of pediatrics, cellular biology, and physiology at Washington University School of Medicine in St. Louis, Missouri. Though I do wish to stipulate that his role here is not representing the School of Medicine, and his comments here ought not be taken as an endorsement from the school. Dr. Hruz is a physician and has published several scholarly articles and given many talks on the treatment of gender issues and Catholic moral teaching. Welcome, Dr. Hruz. I am delighted that you were able to accept my invitation to be a guest on this program. Could you tell the Inter Vitam et Mortem audience a bit about yourself?
Well, it really is a pleasure to be here. I am a pediatric endocrinologist, that is a hormone specialist for children. So my clinical practice revolves around issues related to hormone diseases, covering the whole gamut from diabetes to growth issues and puberty issues. My whole entryway into this topic of gender dysphoria really has evolved over the last decade, probably the last 7 or 8 years, and really it's something that has really come on the scene quite rapidly. And my involvement in this began as an attempt to understand a request that was made to begin a gender treatment program at my institution. So what I was required to do in evaluating that is to understand a little bit of what was going on. And so that has led me into this whole area, studying the scientific evidence behind the current medical treatment recommendations that are being made, and investigating at a much deeper level how this whole subject matter has evolved and really raised very serious questions and concerns about the safety and health of children and at the larger societal level. So most of my research, I do have a basic science research laboratory, so I've been heavily involved in medical research throughout my career. I have had many years where I was working with marginalized patient populations, including those with HIV infection, and so that certainly prepared me well for this current treatment controversy that we're dealing with right now. But so that's just a brief background of where I'm at and how I got here.
Thank you. Can you dissect the issue a bit for our listeners? Could you explain what the definition of gender dysphoria is and what the different treatment modalities are. We can get into the risks and benefits of those treatment modalities, but what has been, up to this point in time, the standard treatment, and what is now suddenly the path of treatment that is emerging, and then we can get into why it may be troublesome.
Certainly. The term gender dysphoria refers to a sense of discomfort that some individuals experience by having a perception of who they are, their identity, as being disconnected or different than their biological sex. So by that, there are individuals who are biologically female that perceive themselves as male, and male individuals that perceive themselves as females. Actually, the whole definition or the diagnosis of that condition has changed over the last several years. It had frequently, in the past, it had been known as gender identity disorder, and that was in the diagnostic manual that psychiatrists use to classify diseases. And with the most recent edition of that manual, there was a change that was made to try to get away from the stigma that is associated with such a diagnosis of gender identity disorder, and beyond that, to make an assertion that what is going on is it's not a disorder at all, that the necessity of having the medical profession intervene has to relate specifically with the discomfort or the dysphoria that is experienced. It's an important distinction because really it changed the whole understanding of this condition. So historically, it was understood that what patients were perceiving in being different than what their bodies clearly declared stood at the level of what was going on in the mind, so that there was something disordered going on with an individual or patient's thinking. And with the change that has occurred over the last several years, they've really changed that and really turned it on its head. And now the assertions are being made is that the mind really dictates who a person is, and that when there's a discrepancy, it's actually the body that is disordered. And so it makes perfect sense that the goal of treatment, if one accepts that premise, would be to alter the appearance of the body. Historically, the treatment was aimed at understanding the psychological processes that were going on, understanding and addressing issues, for example, of anxiety and depression, and really delving into some of the things that might have gone on in an individual's life as far as leading to areas of abuse or substance abuse or other areas in the patient. And so it's really changed quite dramatically over the last a decade or so in our understanding. And so now, rather than focusing primarily on psychiatric interventions, most of the focus has been on some of the hormonal and surgical approaches to change the appearance of the body.
So up until this most recent point in history, this has always been classified as a disorder. The recognition that an individual is having a different perception of the objective reality, the objective fact of the biological sex with which they are born, and this disjunction between self-perception and the objective reality had been classified as a disorder, and appropriate treatment modalities had been focused on reconciling the psychological differences between that perception and the objective reality. And now, if I'm understanding you correctly, that has changed. We are no longer clinically looking at it as a disorder. We are looking at it as merely a condition. Is that correct?
Yes, and it is very well summarized. And it's very important, to note that change in the diagnostic manual was made without any new scientific evidence being presented. It was purely on ideological and cultural grounds that this change was made. And there was a lot of discussion that was made at that time, but there has not been any change in our understanding of human biology and sexuality and what makes an individual biologically male or female. There has been greater attention to put forward this different understanding of human sexuality by drawing attention to, for example, conditions in which individuals present with ambiguous genitalia. It used to be called intersex, now referred to as disorders or differences in sexual development, or DSDs. And really what is missed in that discussion, so the discussion has gone to say there are individuals that don't conform to the form of male or female, and therefore then sexuality is not as we had previously understood. And so this variation is presented as not only in the area of biology, but this question of identity as well. So that is, there are many changes that are going on that are not based on scientific evidence. They're not based on the basic principles that hold medical practice. There really is a substantial change in the understanding of who the human person is as male and female. And I think some of that dissociation has been made possible by some of the things that have gone up, for example, in the area of being able to dissociate the normal purpose of sexual interaction leads to the generation of new life, and with that separation that occurred with contraception, it became easier then to forget that biological purpose. That the whole existence of male and female, not just in humans but across the animal kingdom, relates to procreation. And so that difference in thinking has led to this, at least contributed significantly to this phenomenon that we're seeing now.
I think that's an excellent point, that utter rejection of humanae vitae and the development of birth control, and we've talked before on this show about what it has done societally, 600% increase in fatherless families, and just having Vicki Thorne on this program a while ago too, as we began to talk about just what the effect on society has been because of the birth control mentality, the abortion mentality, and the utter breakdown of the human family. And our view of human anthropology has changed radically, unfortunately. We've, as you have spoken here to the treatment modalities, what was standard and what is now novel, and the lack of scientific justification in some ways for the new treatment modality. Can you speak to some of the risks and benefits that have been established with the two modalities?
Before I do that, maybe I should just at least map out what the specific medical interventions are that are being proposed, and then I can speak about some of the concerns in what they actually induce. So again, the initial approach had been to do psychological counseling and understand that aspect of an individual that has a discordant gender identity. Now what is put forward as the recommended approach is, rather than challenging that discrepancy, to affirm the individual beginning at very young ages socially. Again, that's not a medical intervention, it's more of an intervention that occurs at the very beginning of this treatment modality, but it actually sets the stage for later steps that are being proposed. To affirm somebody's gender identity that is discordant with their sex through name change, through cross-dressing, bathroom access, all of the things that are frequently now in the news. And since I'm a pediatric endocrinologist, I work with children, looking at this happening as early as kindergarten. Yes, and it keeps getting younger and younger when they're putting this forward, and it's gotten to the point where it's not necessarily neutral. There's a lot of suggestion and coaching that is done to help people that might just question what their identity is and trying to assign that with a transgender identity. When a child will begin having the normal process of puberty, again, that transition from being a boy or a girl to being a man or a woman, what is now advocated is that when that leads to greater distress, when the body is changing in a way that the individual does not desire, to give them powerful hormones that actually shut down that normal pubertal process, and these are called puberty blockers. And we've actually used these drugs for many years for children that present abnormally early in puberty. So there are some individuals that start very young at life when they due to a number of different causes, and where we've been able to actively suppress that process. But what is being done in this particular domain is to do this in normally timed puberty, really making either directly or indirectly the claim that puberty itself is a disease rather than the normal process of maturation, sexual maturation. And the arguments are given for that are several. One, that it will alleviate the distress, and that the evidence that we have, at least in the short run, is that does occur. I always like to remind people that it's similar to a child developmentally that's going through difficulty, and if they had an exam next week and you suddenly told them that they don't have to take the exam, that's going to alleviate anxiety, but you really haven't done the child any favor by doing that. So that's the first argument. It is claimed that this gives the child more time to explore their identity and sort through these issues, and we can consider how that actually the intervention itself influences a child's ability to do that. The argument is made that it's completely safe and it's completely reversible, and we can challenge each of those claims. So the claim that it's safe is really based on no evidence. These are medications that are not approved by our Food and Drug Administration for treatment of normally timed puberty. They've been studied in children with early puberty, but they have not undergone the rigorous trials that we normally do to approve drugs for use in different conditions. So it can easily be stated as an off-label use of the medication. So whether or not it is safe in the long run, and I can go through some of the evidence as to why it is not, but it's really a false claim to make when you don't have the evidence to support that. And then the claim that it's reversible can be challenged in that you're interrupting a normal developmental process. What is meant by when they say that it's reversible, that if you stop the medication, the normal signals from the brain telling the gonads to work will become reactivated, and that process certainly will resume. But by interrupting a normal developmental process, you really can't turn back the clock. You've actually disrupted the normal sequence of events in a child that stops pubertal suppression 3 or 4 or even 5 years later can't buy back that time, and there's many other things that go on in a child's life during the period of adolescence that is crucial to their maturation, and so you've lost that window. And what has been shown, the evidence that is available, is that the normal trajectory of this condition is drastically changed. We haven't mentioned this previously, but prior to this new approach to treating this, the vast majority of young children that would present with a transgendered identity, if they were merely left alone, would have realignment of their gender identity with their sex. And the estimates vary, but it's somewhere between 80 and 90% of these children. And we could certainly talk a lot about the scientific studies supporting that and where their strengths and weaknesses are, but it's been a consistent observation. Those children that have undergone pubertal suppression, at least in the published papers on this topic, and nearly all of them will proceed on to the next step of treatment, and that is known as cross-sex hormones. So a male child that wants to present as a female will be given estrogen, and a female who wants to present as male will be given testosterone. And that is typically started around 16 years of age, although the age for which that's been advocated now has dropped, and as early as 10 or 12 years of age, people are advocating for starting these hormones. Powerful hormones that are given in a situation that where the body's being exposed to these hormones at levels that they normally would not see. Failing to recognize that giving these hormones to somebody who biologically is of a sex that's different than they would normally see, it doesn't have the same effect. And it relates to just what we know from a biological standpoint as to why hormones, or any drug for that matter, can respond very differently in males and females. And it's very important to recognize our National Institute of Health recognizes the biological differences between males and females, and in clinical trials that are done for drugs that are going to be developed or used, there's a requirement to study them both in males and females, recognizing that the responses would be different. So there's a lot of dangers in giving these hormones to these children, and certainly at levels that what we're doing is we're actually inducing a condition that in any other circumstance we would consider a disease. So we're in medicine we call this iatrogenic, meaning that we're inducing the abnormality. Again, there are many known and as of right now unknown, but potential risks in doing that. I'll just say a couple of the most important ones. So that probably the most significant effect of this, both the pubertal blockade and certainly when it's followed with cross-sex hormones, is expected to induce sterility or infertility in these children. So that, and that is actually people that are given this intervention are counseled on that. So children who really don't have a full understanding of their sexuality, they certainly aren't able to make the same choices that they would have made later in life about decisions about having children are being put through this intervention that's going to render them infertile.
So in terms of valid informed consent here, it is essentially non-existent. It certainly can't meet a 10-year-old, a 12-year-old, a 14-year-old, we gather assent, but in terms of valid informed consent, meeting all of the qualifications to a high threshold, it would be very difficult to argue that true informed consent is being given by these children.
Yes, and it's rather striking, that in this one particular area, the case is made that the child is able to give that consent when that same child is not given the ability to consent for other medical procedures, or we have laws in place about smoking and alcohol use and things of that nature. Well known as a pediatrician, that children at this age of development are prone to take risk. They don't see the consequences of the long-term actions, and there are many reasons to seriously question, in general, their ability to make good decisions. And so really the ability is given, the child is given the ability to give consent. And what's even more striking is that even a parent who's working in the best interests of their child is often removed from that conversation, so that when there is a discrepancy between the parent's wishes and the child's wishes, in this one particular condition, the parents are told that they are not able to have a say in this. And this is happening both in the clinics and even in the courtrooms where this conversation is going on. It's something that needs to be recognized and discussed, because it's the arguments that are made are really very unique in this condition for saying that.
it sounds like this is not based on a substantial body of empirical evidence. It is not based on what we've seen in case law regarding other conditions. This is truly a unique instance in which the definition of a condition, a definition of a disease, has been radically altered without a substantial body of scientific evidence behind it. The treatment modality that has now become commonplace and is in all sorts of practice guidelines is a treatment modality that really is very, very unique and not based upon the body of evidence that is required for anything else. And here we also have the enormous issue of informed consent, which I've spoken of many times on this show. Just with how important valid informed consent is for any procedure. And here we have 10-year-olds, 12-year-olds, 14-year-olds, 16-year-olds who are not able to meet the definition of informed consent, say, to donate a kidney for someone. We certainly wouldn't expect a 10-year-old to be able to say, yes, I want to do this, or even to undergo certain dental procedures for a child. It is the parent who would say, this is in the best interest of my child, even if they don't wish to do this, this is okay. It is really surprising, shocking that this has become standard practice. I'm sorry for interrupting you. Please keep going.
No, it is something to be very, very concerned about. So I mentioned the infertility, the sterility that's induced by these hormonal interventions. In other areas,
that is absolutely huge. We look at the fertility, we look at how many infertile couples are struggling. It's one of the aspects of what I do in my work as an ethicist. And the distress, the journey that couples who long to have a child and are unable to. And when they were 10, 12, 14, it would not have been a concern at that point. They would have thought very differently than they do now. And here we are taking children and rendering them sterile. We are chemically castrating them. It is troublesome.
It is very troublesome, and I think that those physicians that are engaging in this practice, recognize that particular effect of the intervention to the point where they will tell the child that this is a likely result, and it's a very interesting conversations that are now going on, so that the discussions are. What can we do to preserve fertility in situations where we're intentionally destroying it? So, and these conversations are actively going on, and so that when they talk about assisted reproduction, things where they can then take a child who is, and this is an important point, that these children, and getting back to this question of how this came about with disorders of sexual development, that nearly all of the children that we're talking about here with gender dysphoria have normally formed and functioning sexual organs prior to the initiation of this intervention. So what we're doing, and from a medical practice standpoint, is we're inducing a disease, and then we're working very hard to figure out how we can circumvent that. And the ways that people are doing this are with artificial means of assisted reproduction, and they're talking about young children, about collecting eggs and sperm, and all the it gets quite interesting as you listen to these conversations.
And that is not a innocuous procedure. The collection of eggs itself is a arduous procedure, and the hormones that one is put on before that procedure to collect the eggs, it is not a procedure that is without risk or without pain.
A significant risk, and really a lot of unknowns as far as even the ability to be successful in doing this, and again at a time when these children are not able to really understand what they're consenting to, and it's just from the evidence that's out there that really reflects this point that children are able to understand that even though they are counseled on this, the number of children that even elect to undergo those fertility preservation procedures is exceedingly small, and then there's it's only when they're older where this becomes a major issue. So the sterility is not the only. Go ahead.
I'm sorry to interrupt you, but when we look at some of the bioethical principles, the principles that are standardly quoted in the secular bioethics, realm of bioethics, autonomy, beneficence, non-maleficence, and justice, we are attributing autonomy to children who their decision-making capacity is in question. And if autonomy is something we prize, is the counseling that is being done in some way paternalistic? Are these children being pushed by outside forces, propelled to make these decisions, thus thwarting the principle of autonomy? We look at beneficence. Is this action truly beneficial to the individual on a long-term basis? And it sounds like those studies have not been done, and we'll get into this in a little bit, but there's still an enormous risk of suicide. We look at non-maleficence. Here we are taking a normally functioning biological system, and we are rendering it disease-ridden in some ways. And then we look at justice. Is this a just act? Is this a just act for the future of this individual? Is this a just act for society? Is this a just act in terms of the resources that are being directed to this particular aspect of medicine? And I'm sorry to interrupt you and get on my soapbox, but I see many bioethical problems with this particular issue.
A very, very good point, and we could go through each of those principles in greater depth. I hopefully we'll have enough time to do that. We've already spoken a lot about autonomy, and I want to add to that not only the fact that these are children that are at a stage of development where that's questionable, we also have to keep in mind that these children are suffering with other comorbid psychiatric conditions, a very high incidence of depression, anxiety, substance abuse, and all of these things that really can impair an individual even later in life as an adult to be able to make truly prudent decisions about what is going on. As far as beneficence, the question remains, since this is, at least in children, this is such a new treatment paradigm, that we haven't really looked long-term what the long-term effect is going to be. The studies that are done in the short term have major flaws, and I think that we need to recognize the lack of quality evidence that's out there. The short-term alleviation of the discomfort not necessarily being sustained long-term. And we do have clear evidence that in the studies that have been done in adults, and again, there are difficulties with the way that these studies were conducted, but the evidence suggests that these types of interventions, the affirmation with surgery and hormones, in individuals long-term continue to have high rates of suicidal ideation and indeed completed suicide and all sorts of other difficulties in life. So that it's painted as a picture that by going forward with this approach that it's going to solve everything. And the reality and the evidence that we have is that it's very questionable that this is truly beneficial in the long term, and there's lots of evidence to make us worried that indeed it is not the long-term solution. And looking at adults that have been involved in this intervention for many years, usually on average it takes about 8 to 10 years for these individuals to recognize that it didn't fix their problem, and then at that point in time, trying to reverse the effects that have happened because of these interventions. We've talked a little bit about the fertility issues, and there's a long list of other medical risks that are known or potential risks. For example, in the children that are getting a pubertal blockade, puberty is a very critical time for developing bone mass. suppressing that, they're at a very high risk of osteoporosis, osteopenia later in life, and that's certainly well recognized. Even after you start the hormones that are that people like to argue will reverse that effect of the pubertal blockade, increased risk of heart attacks, stroke, and then the questions about cancer, and there's several issues related to cancer that aren't really well known. Some of the that take many years to develop, but there's also the issue of patients presenting to their practitioner as a sex that really is not what they are biologically, and not getting the screening tests that they would normally have performed, as a result of that. And the hormone levels that we're talking about, exposures, we know from other conditions are certainly capable of, and if not clearly demonstrated, to increase cancer risk. So, and that's just a partial lists, and so non-maleficence and looking at the harm that really can be caused by these interventions. And again, always it's presented in a way that, well, we can accept these risks because we're preventing suicide. But if you look long term, suicide remains markedly elevated. When you look at comparison of people that have gone through this whole gender affirmation procedure, that they continue to have those problems with depression and suicidal ideation. So it's very difficult to argue that it meets that ethical standard. And then, the justice part of it is not only the cost and the use of resources. Very important to recognize that, again, these children are entering in to this treatment with a starting point of having normal sexual function. By engaging in these interventions, they become dependent on the medical establishment for the rest of their life, and so that they're going to be medicalized and require these treatments because they're usually disrupting their normal body function, and so there's tremendous concern about that effect as well.
When we look at other ethical issues, the Belmont Report, the beginnings of bioethics, we look at human experimentation, the Nuremberg trials, Tuskegee, all of these events in our history that we hope we would have learned from, experimenting on vulnerable populations, the rights of children not to be experimented upon, and anything having to do with procreation. And it seems like this one issue truly flies in the face of all that we've done in bioethics to prevent things like this.
It is very interesting that those that are advocating for this particular approach to treating gender dysphoria will not clearly state the unknowns that in the intervention itself. So they have a tendency, there are some of my colleagues that are involved in this particular intervention that will state the reality that they don't really know what the long-term consequences of what they're doing. But the very next sentence is, but we have to do this. And so even if you're looking at it from the standpoint of, we're trying to do the best, we're really addressing a very serious issue, let's proceed with caution in the ways that we do in other areas of medicine. That really has been jettisoned. So that, to acknowledge that there is no long-term data, that there is data out there that raises questions about how effective this is. And even in the discussion about how we generate that information that we need. So the most rigorous of the trials that are going on right now are really observational studies, meaning that all they're doing is collecting the data and looking at the outcome. And sometime, 10, 15, 20 years from now, we're going to find out whether we did something good or bad for these individuals. Not the same standard, and we do this in other areas, but we certainly present this in a very cautious way. There really are very little efforts to conduct experimentation in a controlled way. So even in the question of doing this in children, and it's an area that I'm very much aware of in the area of pediatrics, that there's a proportionately, there's less studies that are done in children because of these concerns about the child's ability to give consent. And the normal safeguards that we usually put forward are higher when we're conducting research in children, except in this particular area. And many people frame the question that it's an established fact that this is the only way and it's the best way to proceed with care, and not really presenting this that we don't really know what we're doing, and that this is experimentation. There's another component of the experimentation that's going on when we also bring into this the social affirmation component, so that that when it's being put forward that even before you engage in hormonal treatment or even propose surgeries, that you need to affirm this individual in the social setting, it is now being very strongly put forward that people within the community, the teachers, other parents, and classmates need to affirm these individuals. And I think it's well-intentioned, but what is not recognized is that in doing so, you're recruiting these people from society without really getting their consent to be able to participate in that unknown, and essentially, I would say, research approach.
Sure. You are asking this 8th grade class to participate in a social experiment, and what is the effect on the other members of that, that individual class of folks who are being asked to affirm the child with surgery or the child with gender dysphoria. It is an amazing set of events that I don't think anyone could have imagined 40 years ago.
And the effects of that are not neutral. So that there are many questions that can be asked, and we can do this. I'm a physician scientist, so I always think about this in terms of hypotheses, or we think about what might be going on. It's amazing. We haven't touched on this yet. The number of children that are presenting with a claim of a transgendered identity is really skyrocketing. I mean, it's increasing dramatically over time, almost exponentially. And you can ask the question about what used to be an incredibly rare condition, whether this social affirmation and what's being put forward is actually influencing children to assign any sort of developmental difficulty that they're encountering to being transgendered. And it's not been studied. So you can put it forward as a question, but there's a lot of concern that there may be an influence of that. Now, what the claim that is made is that these children always existed, and that now there are centers that are providing these affirmation medical interventions. They're just coming forward. But there's really no evidence to support that. And what we do have is emerging evidence. It's very early that some of what's going on in for example, in social media and the chat rooms, and even when they're in the medical care setting, people presenting with all sorts of difficulties, depression and anxiety, that assigning gender issues to that when it may or may not be directly related to the problem that the child has may be pushing children toward a path that will have certainly lifelong consequences when there very likely was a different solution that might have had more benefit for that child. So again, many questions that come up related to this. It gets very, very contentious, and in the discussions that are going on, there are very strong opinions, but very many of them are not based on solid evidence. And so there's a tremendous need to gain that evidence to be able to put forward what is the best treatment approach. And in doing so, really get back to this question about, how you even make the hypotheses, what you're going to study, in terms of what we understand about the human person. So this is really important that we can be recognize this basic fact just at the biological level of sex being related to procreation. But there are many other dimensions of human sexuality in relational, the very fact of understanding that people are created male and female. It's the only biological system in the body that is not complete within the individual. So we talk about a reproductive system. A male does not have a complete reproductive system, nor does a female have a complete reproductive system. It's only complete when you have the man and the woman together. And as we start looking at this, the way that we've been distorting our understanding of sexuality and making the claim that whether one is male or female is solely at the level of what one thinks, independent of what their biology is, then leads to people proposing the treatments that we're talking about without considering what the long-term effects are.
There's a sense of objective truth there, too. Even if one mutilates one's body, first with hormones, then with surgery, there is still the objective reality that the DNA that you carry around, the chromosomes that you carry around, you are either male or female, and those are not going to be altered by any of these other interventions.
It relates to who we are as human beings, male and female, and it really, the way that the body is designed as male or female has much to do with those differences that we see, and they don't go away at all. We already talked about earlier, the effect of medications that we take having very different effects on males and females. Sure. Some of those differences are related to the hormones that our bodies are exposed to, but some of them do not. And we can look at many different medical conditions where we've been able to separate out the hormonal effects from the effects that are present really from the time of conception, so that there are changes and differences to our DNA that's present from the time of conception, where we have changes not just in the sequences of the DNA, but the actual, we call them epigenetic changes, where they drive whether different programs are turned on or turned off, and those remain. So that, and then we can, there's much that we know about differences, not just at the level of the brain, but in every organ of the body that are really affected. So who we are as male and female is something that is, it's in every fiber of our being, literally, and the attempts to deny that by the argument, that we can, our mind actually dictates who we are as human beings, certainly has consequences, and it's something that, that could be a whole entire topic of discussion, but it's certainly fascinating to really see the consequences of really changing that way of thinking about who we are as human beings.
And as you said, in justice, it also has not only for the individual, but for the rest of society that is being asked to engage in the social experiment of affirming a certain individual who has elected or who has been pushed into the changes. The line between affirmation and herd mentality becomes very small. Are we being asked, is there a fad mentality among, as you said, in the chat rooms and things? One of my daughters was telling me the other day that she was concerned about a friend who was was on a forensics team. And some of the discussions that were coming forward from the forensics team were troublesome. And she asked her, why do you always pick topics like suicide and gender issues? And she said, because I get better points that way. And the object is to win at the forensics competition. So if I talk about suicide, if I talk about having gender issues, even though I don't, I get more points. Well, are we pushing people into this, and what preceptors, what teachers out there are picking up on these, and where does that go then?
And it touches to the human need and thinking about child development. The children at the junior high level are just by their very process of what's going on developmentally struggling to understand their identity. They're questioning many things about themselves and about the world. And they're really trying to figure all of those questions out. And when in the process of doing so, you have a condition that is elevated, it's put on a pedestal as far as getting that what they're searching for, as far as that affirmation. Certainly there's much that we need to understand at a greater level from rigorous science, but certainly what we know intuitively leads us to question what is going on and how that is influence these individuals.
Once individuals embark upon this merry-go-round or are put on it, what pathways are there for them to exit it if they choose to?
It's very
so many get caught up into it.
Yeah. So it's very interesting, and so a lot of the people that are very committed to this particular treatment approach will support and affirm and help the individual in making the initial transition. But once an individual says, this didn't help me very much, and decides to go back, they actually are confronted with a number of challenges, hostility from the people that were originally supporting them, who are claiming that they're working in their best interest, and they're claiming that this is a neutral, see what works for you, and whatever decision you make is fine. The transition back is, from the stories that I've been able to hear directly from individuals that have been affected in this way, consistently show the challenges that they experience in making that realignment of their gender identity, or at least their expression of that gender identity in accord with their sex, a very, very difficult process. There's a growing number, and that's why we probably don't hear as much from these individuals, because they're not seeking the limelight, and they are being attacked when that occurs. But it doesn't take much to find these individuals, and again, many of them are, once they've transitioned beyond into the adult years, and again, about 8 to 10 years is the average where people desire this detransition to occur. You can't dismiss their own personal experiences. Even people that are advocating for this approach, it doesn't fit the storyline that they're looking for. But I want to touch a little bit on this question, that just to recognize that these are individuals that are truly suffering, and we need to really recognize that they are suffering. They have, again, we already talked about all the other things of depression and anxiety and behaviors that they take that provide difficulty for them. So that there needs to be a compassionate response. There needs to be an effort to understand the condition and understand better what is causing it, and proposing interventions that will be truly helpful. But I think in looking at the evidence that's available right now, we have to question whether what we're doing truly is beneficial. In fact, there's a lot of reason to believe that it's actually harmful. So we can maintain that understanding and respect for human dignity. We can work with them to avoid situations where they're being bullied or that they are subjected to unjust discrimination. But that doesn't necessitate that we forget about fundamental questions of biology, that we don't critically question what's going on with an intent of providing what's in the best interests of these individuals. So, I think that we need to remain in the dialogue at the same time while we're questioning these approaches as to what they're actually doing, not only for the individual but for society as a whole.
You raised some really important points. Yes, there has to be a recognition of the suffering that is going on. It has got to be a tremendously challenging and lonely road One of the questions that I always ask on this program, especially as we get to this point, we are Holy Apostles College and Seminary. WCAT Radio is an arm of Holy Apostles. And as a seminary, a good portion of our listeners are men in formation or formators. They're seminary rectors, bishops. What can you speak to that audience? What advice would you have for them in terms of pastoral care for those who are suffering from gender dysphoria?
That's a wonderful question, and I think it really speaks to seminarians and priests in their role as pastors really can have an opportunity to provide very, very important support in addressing these individuals. So, being able to journey with them. So I think that, they're probably better than other vocations are situated to be able to understand and affirm that individual's human dignity. I think that that very, very clearly affirming that they are children created by God and loved by God, and really be able to foster that love, that they are loved by their Creator, they're loved by the priest and those that are trying to do the best for them. And I think it's a question of accompaniment. How do we best enter into, and people, present with all sorts of difficulties throughout life, and be able to understand where they are at, to accept them and affirm their human dignity, affirm the fact that they are loved, at the same time not with the goal of staying there, to really to direct them toward really an eternal goal of that goes beyond what they're experiencing in the present moment, and be able to journey with them, to accompany them, to love them, and to help them see that. Many of these individuals that are affected for a variety of reasons have low self-esteem. They really are searching, like we all are as human beings, searching to know love. And a priest, and certainly is, I think, exquisitely prepared to be able to present that as what love is and what love means, and point them to the source of love, the person who is love, our Creator God.
Oh, that's beautifully stated. That is beautifully stated. Thank you for sharing that, Dr. Hruz. That knowledge that we are created in the image and likeness of God, and we've talked about this on this program often, that image is something that is imprinted upon us from the very moment of our conception, and the likeness is that capacity to grow into an alter Christi, to grow, to accept that, and to grow into another Christ, and to reflect that love of God in who we are. We're all created with that image and likeness, in the image and likeness of God. And our seminarians, our men in formation, and those who are helping to form them can help direct them when dealing with folks with gender dysphoria to reaffirm the beauty and the dignity of who they are as children of God, forever loved from the moment of conception for who they are. Well, we are about at the end of our time here, and this has been a fascinating journey here. Thank you so much for spending the time with me, Dr. Hruz. Thank you for what you do, and for being a voice that speaks in defense of the individuals who have this condition, and a voice who is willing to go against, at times, others who are not willing to look at evidence-based medicine and to look at the long-term risks. A voice of caution, a voice of reason, and a voice of faith. Thank you very much. May God bless you in your work.
Well, thank you. It's been my pleasure to have this opportunity to be on your show.
Thank you.
We hope you enjoyed the program and will join us back for another show on WCAT Radio. This is Sebastian Mahfood. Good day.